Buenos días a todos y todos los que estamos conectados en este día tan importante.
Good morning to you all. Good morning to everyone that's connected today. Today we will have a seminar to strengthen and transform the health system in the Americas. We want to wish everyone welcome. We have a very big public. We are very happy and we are ready to start with this day to improve our region. My name is Mónica Padilla. I am the Health Services Coordinator at OPS Colombia, and I'm going to be in charge of moderating this event. I would like to give you some housekeeping indications. We have simultaneous interpreting into Spanish, English, and Portuguese, and so you can choose the language of your preference in the lower part of your screen. We also have captions that you can activate by using the CC button. You can also adjust your Zoom video so that you can see the presentations in your screen as well as the speakers. You can send your questions through the chat. And we hope that the space for dialogue will allow us to build together what we need. So please don't be discouraged. Please put all your questions in the chat box for our panelists. Also, don't forget to turn off your mics during the whole session. And now I'm going to welcome Gina Gambini, representative of the PAHO in Colombia. I'm going to act as a moderator, so I will give you the times that you have to speak, but I will not be telling you when your time is over because our speakers today are very high profile. So the idea is for you to check your time. So Dr. Gina, I give you the mic, I give you the floor. Good morning, Mónica. Good morning to every one of you. Good morning to all the people that are connected in this first seminar of a series that will be very important for all the countries in our region and in the world. I want to greet the Honorable Minister of Health and Social Protection, Carolina Corcho from Colombia, Honorable Health Minister from Chile, Begoña María Yarza. We can see her there, connected with another colleague from the ministry. Hello to the Minister of Brazil, Dr. Marcos Fernandes Vinícius Diaz, and we also know that we will have Bolivia's Vice Minister, Dr. Hidalgo. So welcome to all of you. Thank you for leading such important processes in the countries of our region. Also, hello, Dr. Fitzgerald from the systems at PAHO. And I greet you from our regional office at PAHO. We thank you for your participation in this very important seminar today. Your presentations, the panelists' presentations and interventions, as well as questions, will give valuable information related to the challenges faced by health systems, and also the implementation of strategies to have resilient systems that will achieve universal health coverage in the Americas. COVID-19 pandemic has had a considerable impact in health, in life, and in development for our Americas region, as well as in the world. And it has exposed and exacerbated structural challenges in our systems that have affected our response capacity, making inequalities more powerful. And this means that we need to act effectively to guarantee access to health as a right that we have in our societies. In September 2021, ministries of health in this region adopted the strategy to establish resilient health systems, and recovery after COVID-19 to maintain and protect the progresses that had been made in public health. And so in this resolution, the mandate was for PAHO to provide technical cooperation to strengthen capacities and promote cooperation, regional dialogue, and the exchange of knowledge and experiences during the pandemic, because we need to reinforce our health systems based on primary health care and health, working on networks and taking care of the population's health, supported by a strong state capable of responding to challenges and different realities. Resolution gives a framework to talk about these challenges, and at the same time, it um, seeks to reinforce what has been stated in the high-level commission. So 40 years of Alma Ata and the 30-30-30 Pact, primary healthcare for universal healthcare. And this universal has four resolutions: transform health systems on the base of primary health care approach, recover and sustain progresses in public health, and go back to universal coverage, reinforce leadership and governance through essential functions in public health, reinforce the capacities of the networks to deepen access and have more social protection, including actions that have to do with environmental factors of health. Many tools and lessons learned are present in our region in these strategic areas, and today we will listen to a Colombian Minister of Health, as well as for Chile, who's the joint minister in Brazil and the vice minister in Bolivia. All these innovations and this boost that we want to give to this reform in our countries. This is why it is imperative to create opportunities to share these experiences and identify relevant areas for technical cooperation while we work together in strengthening our health systems to achieve universal health. So to facilitate this regional dialogue and respond to the mandate received by the countries, your secretariat from PAHO, made by yourselves, is starting this series of virtual seminars that will take place until December this year. Today's seminar will focus on key aspects to transform and reinforce systems to achieve universal health. And the next sessions, we will have the opportunity to deepen financing and resilience, and how the health reforms impact access barriers, as well as the challenges to achieve resilience and universal access, as well as social participation is a key element in transformation and reinforcement of health systems, regulation of financing, provision of health services, a framework for the Americas, and the governance of the systems. All these topics are key to achieve our common goal of universal health, and they all require firm political will that has been shown by the Americas region to face the challenges in our health systems. There are 1,920 people registered today, and 500 are connected right now. And today we have players that are involved in the governance of health systems. We have international players as well that are involved in reinforcing health systems. We also have professionals and technicians that work on the design and implementation of policies. We have representatives of the civil society, of the academia, PAHO staff, as well as our technical staff and people from WHO, both from national and regional centers. Thank you very much for your dedication and thank you for being present in today's seminar. We invite you to stay in this community of social players that seek to impact and improve our population's health from our different functions and attributions. Uh, Reaching universal health requires our joint effort and collaboration. And so from PAHO, I repeat our commitment to give all our technical capacity and all our expertise to support countries and member states in achieving this goal. Thank you very much.
Doctora Gina, para complementar entonces,
Thank you very much, Dr. Gina.
Dr. James Fitzgerald, director de
Now I'm
Sistemas
going to give the floor to Dr. James Fitzgerald from WHO. You have 5 minutes. Thank you very much, Monica. I'm not going to use these 5 minutes. I just want to salute Minister Yarza, Minister of Health in Chile. It's great to see you again with Jaime and the whole Chilean team. You are going to universalize EPS in Chile. That's absolutely wonderful for universal health in Chile. We also have Carolina Corcho from Colombia and her team with a very important task to ensure more integration, social protection in Chile. And we also have our colleague, the Subsecretary Fernandes Diaz from Brazil. He is also a key player in Brazil in developing the SUS. We know that this project has 34 years and now they have had a very important constitutional reform in Brazil and they have achieved very important results in terms of health. And so they keep on improving this sector. I'm not going to say much more because I think that Gina has said everything. We at Washington are committed, fully committed to work with PAHO country offices, as well as with our partners in the region that are working on this topic to improve health. If there's something that we have seen during the past years is that we cannot work in an isolated manner. We have to articulate in terms of health protection, social protection, financial protection, and economic development. This is a fundamental, a key lesson that we have learned from the pandemic. And this is why at the United Nations and ECLAC and other expert networks, we're going to create a very strong force to work with the countries substantively. Okay, so Mónica, thank you very much and great luck in these deliberations. Thank you very much, James. We're ready to start with our panel. Here we have 3 representations. We're going to start with Dr. Yarza, the Minister of Health in Chile. Then we will have Dr. Corcho, Minister of Health in Colombia. And then we will have Dr. Marcos Vinícius Fernandes that is also going to participate. So, Minister Begoña Yarza, I invite you to participate. We have 8 minutes. I am just going to say that. Please, you are free to speak to our community. Thank you very much for the invitation. The PAHO invitations are always invitations from friends, invitations from people that walk with us down our path. So thank you very much for this invitation and thank you for the platform to tell you what we are doing in Chile, what is our dream, and where we are coming from to build this dream that is to transform the health system. And of course, the results And the result has to be, of course, a universal health system. So we come from a health system that needs to be improved. And why? Because our health system has been going through the pandemic for the last 2 years. This has meant to use all of our tools to address the pandemic, but we also have um, um, an epidemiologic and demographic change that needs to be solved. We have had this for the past several years. More than 11 million, we have 19 million people in Chile, and 11 million people in Chile have chronic illnesses. In Chile, every 10 years, we assess the results of our sanitary system. And what has happened from this point of view is that we have had a demographic and epidemiologic change in some conducts and some behaviors. And we have more and more people included in this group of risk and chronic illnesses. We have had a National Health Survey in 2010 and in 2017. So we not only have the pandemic, we also have this pandemic of conditions and illnesses and an aging population that's around 12% of our population. So 12% of the population is above 65 years of age. And as well as in many countries of Latin America, we have two significant elements that describe our sanitary system. We have a segmented system in terms of financing. We divide the population according to its risk and according to its illness load. And then we have the provision. We have a fragmented system. What does this mean? We have a provision of private services, a provision of public services, a provision of services from the armed forces, a provision of services that has to do with professional illnesses and work accidents. So from the point of view of financing, what comes from FONASA, which is a public fund, it has the population with a higher risk. So the adult population that's at FONASA has 35% more risk than the population that's at ISAPRE. So here, in this group, we have um, 3 more times elderly citizens, 56% of people that completed their school education, and 8% of affiliates that have one or more chronic illnesses. And the people that are at FONASA have also 3 times their expense per capita is 3 times lower. And so at ISAPRE, what we have is a population that's younger, with less risk, and that has 3 times more expenses. So this is what I mean when I say that we have a fragmented system. So there is a health for rich people and health for poor people. Okay, so let's look at, for example, effective coverage according to insurance in Chile. We have FONASA and ISAPRE. And for example, in yellow, we have diabetes, and in gray, we have depression. In FONASA, effective coverage is lower. And in the case of the use of services on your right hand, the people that belong at FONASA and at ISAPRE, uh, at FONASA, people use more services for specialists as well as for general consultations. So we have differences in access and in coverage, but we also have differences in sanitary results. When we look at sanitary results that have to do with public insurance or private insurance, well, we see that there is a very big gap in terms of child mortality and the capacity of the system to close these gaps. So the richer communities have much better results than poor communities. Uh, Poor communities have 2 times more child mortality than rich communities. So what we have is a lot of inequality. And when we were confronted to the pandemic, these differences became more these differences became higher. And so Chile, that is a medium high income country, has to compare itself with other countries. And we have also to look at similar countries.
We also want to point out that it's very relevant for us because we are dreaming and building health reform as it's that people, because of the social conflict that started in October 2019, a social movement in which the health issues were really one of the most important issues that were that were motivating the protest. So this health reform is definitely one of the most important tools to solve this social conflict. And there is an expectation of change in Chile, a huge expectation about that. And it's very relevant also that people tell you about their need to see a change, about their strong desire to have a health system that is not discriminatory and that the person finds tolerance and a warm welcome. So in Chile, dignity should be dignity in health, and health reform should be one of our strongest projects. In our government, we're going to start the health reform to arrive at a universal health system in a medium term. So this is ratified. This year has been ratified in June. And we want to, first of all, start with a financing reform that is the basis that allows to universalize not only the access and coverage of health services, but it also tells us, it also states that we are presenting a project this year to the Parliament. And the strategy would be a comprehensive strategy to integrate health services with primary and health care services And we are going to start with that in order to arrive at the universal health care. And the axis would be, as I say, primary health care. And of course, the public policies that generate a healthy environment. So our universal health system should be resilient, not only for the pandemic and for other infectious diseases, but for all the challenges of our Latin American countries. And this is what, well, here you see the big issues in our reform. This is a scheme that shows you how this health fund, that is one of the first steps, will lead us toward and not financing, not not a segmented one, but one that responds to universal healthcare principles. So we would have a national health service that would be a resilient and comprehensive one. And there are two important steps here: the primary health care, universally primary health care, and zero co-payment, because we want to arrive at the broad population, because a change is not done with minorities, but with majorities. So the co-payment zero principle would guarantee universality of healthcare and would allow us, well, 3 weeks ago, we took the decision that starting with September 1st, in Chile, no person that is part of the national health system will have to pay for care. So there would be no financial barriers for access to health in Chile. And I end with this, the reform is a challenge, but we have to learn from our own history in our countries. And there was a reform, a health reform in 1952 that was carried out by the then senator, Dr. Salvador Allende, and Dr. Eduardo Cruz Coke, that already stated the principle of our universal and sustainable health care. Thank you, Dr. Garza. Thank you very much for your participation. We now want to go on to our minister, Carolina Corcho from Colombia. It's a great pleasure to have you with us, Mrs. Minister. Thank you very much. Special greeting to PAHO and to the Minister of Health of Chile, Dr. María Begoña, and to the Assistant Secretary Marcos Vinícius from Brazil, and to all of you. Thank you very much for this shared space. We greet you from Colombia with the first popular government in the history of our country that is facing huge challenges in terms of health. My presentation will be 10 minutes long, so I want to not to show you slides, but to explain you a little bit about our proposal and also about the Latin America, Pan-American dialogue we should establish. In the government of Dr. Gustavo Petro, there are two very large challenges that we have to face in terms of health. First of all, we have to complete the peace transition process with the guerrilla movements, and we are also going to start the process of peace dialogue with the ELN and with other armed groups that are linked to drug trafficking. This is a challenge in terms of peace. But the second challenge for this transition between this transition government is to overcome neoliberalism and the negation of fundamental rights, because fundamental rights became business through the privatizations that were carried out in Colombia. And here the central reforms are the reforms to what we call um, the pension fund system and the healthcare system that were hugely privatized. And this is one of these are the most important reforms that we are going to establish during this government starting next year. This health reform is not only an initiative from our government, but also from social movements of civil society and from intellectual democratic movements. We have been studying about, we have been studying these and analyzing these problems for many years and establishing possible solutions, because the present systems do not correspond to our reality. As we said, Colombia does not have private, did not have private insurance. And in 1910, a private healthcare system was proposed. But the public health system that is supported by the national budget and also by the contributions of workers were divided among 200 administrators so that they can manage these resources and hire clinics and hospitals. But this led to a huge chaos because these intermediaries created a huge problem for all our population. More than 150 of them have been closed, and there are $1 million debts to the clinics because there were no technical reserves, no reinsurement processes. And so it was really a huge expense of the public resources of Colombians that were lost forever, because the state has not been able to find out where these expenses went. This is a very dire situation in Colombia. The system almost did not develop a public information system in the last 30 years. So we do not know about the destination of these resources. And so it's a state that didn't know who these private entities were to which they distributed resources. And but we have a huge peasant and worker population that is not insured in their health situation. And in rural areas, the death rates are almost 5 times higher than in cities, because the public expenditure were not equally distributed among the population. Many of these resources are concentrated in large cities and in intermediations, ignoring 23 million of our population. In the urban areas, the indicator that is most important for us and that tells us about the difficulties in the system is tutelage. And in Colombia, the Constitutional Court and the judges that have established a very important and very wide-reaching reform of the health system. And so, but the state, the executive, gave away these services to private entities. So the Constitutional Court was the one that established the fundamental and universal access to health care. So we have to look for universal health care that we have not achieved in Colombia. We are not questioning the insurance system because this is a public insurance system and the resources are solidarious resources from the workers. But the intermediation is what we are really questioning, and the reform wants the resources to reach the networks, the private and public healthcare networks directly without intermediation, um, and of course, stressing primary healthcare. So, all the system, well, the 10% of the budget was spent for primary health care, but there's, well, we also have to take into account that there were the intermediaries in between. So if we want to talk about primary health care, the resources of the state have to go directly to that issue. And we believe that in the end, it would have to be the 30-70 proportion, 70% for social insurance. And in this reform, we also want to formalize the services. 80% of healthcare workers do not have a stable contract. They pay them each 3 or 4 months, or they're not paid, and so we need to establish a formal labor healthcare worker system. We need a policy of sovereignty in everything that has to do with health and pharmaceuticals. Regarding the monkeypox, our government was stressing the preventive measures, and we sent our resources to buy the drugs from a certain lab, but the lab forced us to pay for all their research, and so we didn't sign the contract because this went against the constitution of our country. And so in that sense, the idea is that it's not possible that when we have need to purchase services or drugs uh, and have access to technologies, we need to reflect on the possibility of acting as a region. So in the long term, we could start to build our sovereignty in vaccines in order to support our own health services and be self-sufficient and establish a multilateral agreement so that the sovereignty of our states is not affected, and we can guarantee the right to life. And we would need the possibilities to have access and buy the medication, the drugs, and the vaccines to protect the lives of our people. Of course, we will be open for the purchase of vaccines, but we want to leave you with this issue for reflection. Thank you very much, Mrs. Minister. And I would like to welcome also, before giving the floor um, to the Vice Minister of Bolivia, Dr. Alejandra. Welcome. We're very happy to have you here with us. I would like to give the floor to Dr. Marco Vinícius Jaime Diaz so that he can share his presentation with us.
I would like to thank all of the officers from OPAS, and I would like to ask you for leniency. I will speak in Portuguese. I thank you once again for the invitation and the opportunity to be here with you and speak about the Brazilian healthcare system experience. In fact, the single health system is a point of pride for Brazilian culture. It is a landmark, and it was built from the grounds up in the 1980s using and based on the population's legitimate needs for health. We have worked towards perfecting our system, and we are very proud of it. In Brazil, we have a system that is based on universality, integrality, equity, and most of all, social participation. And now today I will speak to you about how our system is organized in terms of social participation in designing and stewardship at SUS. And I will also speak to you about the supplementary or complementary healthcare system, which is of a private nature. And this is also allowed, and it exists in Brazil. So we have a universal healthcare system that caters to all of the Brazilian population, but about 25% of the population, besides the single healthcare system, this also has a private healthcare plan. I will speak to you about how SUS came to be. It began through social mobilization just before the 1988 Constitution was established. And from the very beginning, the idea of social participation is its very cornerstone. It is a tripartite system. It includes municipal, state, and federal participants, which come together to reach a consensus in terms of public policies. We also have federal committees, state committees, and municipal committees for healthcare. In these committees, we have participants that represent civil societies, and most importantly, 50% of the people in these committees represents system users. And now I would beg you a bit not to give you a lesson, but speak from the heart, because I come from SUS, both as a person and as a doctor. All of my experience is based on SUS. And I believe that the pandemic has shown us the importance of having a universal healthcare system, mainly and especially in a continental country such as Brazil, with a very diverse population, very cultural diverse population. And I think SUS has been a wonderful example, not only for our neighbor countries, but also for the world, that and showing everyone that a universal healthcare public system is key to caring for a population's health. So now we will have a major challenge, which is stewardship and governance, including popular participation, not only through the support of civil society in designing and monitoring our system, but we all are also very concerned that this participation of civil society is also working to monitor the clinical results that we obtain. We believe that this is a plus, let's put it like this, in terms of civilization and civility. The user has information regarding the quality of the services they enjoy. Nowadays, in cardiology, for example, we have a program which qualifies these services that supplies healthcare services according to their performance, both qualitative and quantitative. The population must be aware, for example, of the hospital infection numbers, mortality numbers, the number of surgical interventions, mean time for hospitalizing, and we believe that if this is based on deliveries, it will help us qualify our healthcare system. And now we'll very shortly speak about the private healthcare system, which comes to us and tries to add to the public healthcare system. The Brazilian Constitution allows for the private healthcare system to act only as a supplementary service. 15% of the Brazilian population can access several types of private coverage. And in Brazil, there is a nationwide institution which regulates this service. There is a very asymmetric feed of information between users and service providers. So due to this asymmetry, the Brazilian state set up this regulatory agency which helped us provide transparency and control for the private healthcare market. We know that health is priceless, as we've seen before, but certainly there are associated costs. And these costs really are a huge challenge because even though the budget needed would need to be endless. And so now I will wrap up once again, trying to speak about Brazil's investiture through the President Jair Bolsonaro and the Ministry of Health in providing healthcare. I would like to thank Dr. Socorro Gross, who represents PAHO in Brazil, and the partnership they have set up with Brazil, the Ministry of Health, and the public and universal healthcare system in Brazil. And I am at your disposal to share whatever information we had and whatever information you need. I thank you once again for the invitation to be here part of this important meeting. Thank you.
Thank you very much, Mr. Secretary. And we thank all our panelists for their words. And unfortunately, the minister from Bolivia has some connection problems and cannot join us. She was just with us for a few minutes. I wanted to tell you that we should start with our questions. Please put them on the chat because we are here with authorities that are taking care of our healthcare systems in our big countries, in our important countries. And we have some reflections, for example, about the debate of financing sources, the financing sources that are at their disposal, the problem of the pandemic, and the setback that according to ECLAC would be about 10 years, and how we could how we can access the combination of financing sources we're talking about. So I would like to ask our participants for a comment about, for example, the relationship between the financing sources and how to and the quality of the services and the differences that sometimes are found between public and private services, and the other public and private care. And the other question is, what do we do about migration, the people that are migrating around our countries? And we need to, well, there's this population that goes from one place to the other, and this makes it difficult for health systems to provide appropriate care. And at the end of this meeting, maybe we could have some proposals for our common work ahead. So we have three great areas, and I would like to go to ask all our panelists to tell us their answers about this. I will start with the Minister of Health of Chile, Dr. María Begoña. Well, regarding this question, I also read some questions in the chat and I found the comments very interesting. So I thank you for the questions. And of the participants in this meeting. And the health reform, what it will try to do in regarding services is not only better coverage and better access, but also we have to find a way for resilient and efficient health systems. Nowadays, this efficiency is based on short-term measures. And what we propose in this reform is that efficiency and effectiveness should also be have an institutional basis. We are thinking that we need sciences and technological and scientific solutions for our health system. And this would bring about a greater institutionality in our service provision that would be safer, of higher quality, and of course also more efficient. And but this cannot be a short-term solution. This has to be something linked to the results. And so this greater efficiency and universal insurance would bring greater resources for our health system. And we would like to include in our project a line of, well, to create a people-centered and community-centered services, because we have to look for the evidence available and establish an administration that really puts people first. And it's not only individual and shared decisions, but the public policy, starting with the research of needs, and the resulting policy has to be centered on our people. And quality of care is, it means that we have to put people in the center of our services. And we need the opinions, and we need the participation, we need popular participation to establish a structure, a central structure, or territorial and regional structures that makes it possible to center the policies on the real needs, and it's not only designed in our offices. And so, well, it has to be established in a more systemic way. This would be one of the principles of our reform, that has to do with the fact that this roadmap is centered on the person that is part of the national insurance program, or on the part of the private insurance program. Our government is bases this care on the same universal principle, and this reform has to improve standards. Thank you very much, Dr. Begoña. I would now like to go on to Dr. Carolina. And well, there's several questions, not only for Colombia, but well, let's start with this first block. So go ahead, Dr. Carolina.
Okay, so there are many questions here. So first of all, the financing of the system is public. It has always been public. We have financing through solidary cotizations by the workers, and another ones go through the nation. And a tributary reform that we had in Colombia, there was also a contribution from the entrepreneurs, and this was and employers, and this was reduced. But the decision that the government has made is that we will continue with the contribution from the nation and the contribution from the workers. And the and no measures that we take will affect the financing. We believe that we have to have between 7 and 9% of GDP, and this implies several tax reforms because we have had very regressive tax reforms. And right now we have a progressive tax reform. We are among the OECD countries that collect the less, and we have huge tax evasion. We also have tax cuts that are being rediscussed so that we can obtain everything that we need for social policies. The reform does not affect the funding. The funding has always been public. And regarding EPS, so utilities, we have received, we have 17 in process of liquidation, and they have not been able to manage public resources. And so after that, we're going to have liquidation processes that are very delicate, and we're going to have to guarantee the health service and the right to health. And with these liquidations, you have two options. Either you look elsewhere and you say, we're not going to do anything. This has happened for many years. A lot of some intermediaries show that they could not comply, and only 5 comply with very flexible characteristics. And then the country has an oligopoly, and this is not good for fundamental rights. And so having an oligopoly managing 10 million citizens is not good, because some studies show that the intermediaries that are good are those that work in big cities. They have few affiliates. They have private and complementary insurances, but when they don't have these features, they're not good. This is why we need the reform, and the reform implies a new institutional arrangement where the state recovers the resources and pays directly hospitals and clinics that are organized in networks with an information system that's public, that's in online with big data, that has transfers, and that's for all Colombians. This is a structural reform, and it has a progressivity principle, and it has a strong, and it needs a strong implementation of primary health. This was abandoned in Colombia because we had very high very costly systems, and so it was left to governors, foundations, etc. But we didn't have a structural policy for the health system. So that's the reform that we are going to have, and oligopoly is not a good idea, and the vaccinations show this, because when there's an oligopoly that has resources from the state, it's what happened when their patents were freed in the World Trade Organization, so that the laboratories could produce everything. And this was not possible because the oligopolies had captured the organizations that are regulated by the state. Thank you very much, Dr. Carolina. Now we would like to have Dr. Marcos Vinícius. In Brazil, the private sector during the pandemic, we want to know what are the difficulties that we have to guarantee sustainability and access. Please go ahead.
Yes. As we said before, in Brazil, we have a single
we
healthcare
have a
system
unique
which
health
caters both
system
for
that
private
has
and
the public and the private
sectors.
part.
Even the private
Even in
sector here
the
is
private
regulated
sector,
by the Brazilian
even the
government.
private sector is regulated
Therefore,
by the Brazilian government.
during the
During the pandemic,
since Brazilian solidarity is known worldwide,
solidarity was
there was
intensified,
no
and there was no discernment, there was no
in terms
differentiation in terms of
of
to offer assistance to the
working to
population.
help Brazilian
The
population.
private
This
sector
private sector helped us out,
supplying
giving us
beds.
the means, and
Many
several
private groups have built
campaign
hospitals,
hospitals, charging absolutely nothing to the Brazilian
hospitals without
population
charging
to
anything
face the
to the
pandemic,
population,
especially in its
to
beginning,
make
where the risk
to
of
act during the pandemic, especially at the
losing people
beginning,
to
when there were no
intensive therapy
intensive care
was
unit
real
beds for all
So
Brazilians.
the Brazilian government
There was
attempted to
harmony, and it was
coordinate this,
coordinated by the Brazilian government
working
that
with
integrated the
private
public
sector
and the
to
private
bolster the public sector somehow.
sectors. Thank you very much, Dr. Marcos Vinícius. Now we have a series of questions, as you can see. Now we have like 50 something questions that are appearing. So I would like to do the following for our panelists. One of the things that is asked is payment systems today are very, do we see any alternative to minimize the perverse effect of funding by demand that goes against promotion of health? That's one of the questions that has been asked. There's also the the question of human talent, of human resources. How can we cover these human resource gaps that we have in all countries? There are questions about the use strategies to guarantee this access through professionals that are qualified in distant areas. And there is a specific question regarding the role of universities at this time of training and quality assurance. What is a link with the academia for our health services? That's a question from Uruguay. Now I'm going to ask you to react to these questions. I would like you to answer to these questions, and then I would like to ask the speakers to make some comments before reaching the end of our session. So I'm going to give the floor to Dr. Begoña, and I can imagine that you also looked at the direct questions for you. Please, Dr. Begoña, go ahead.
Ahí, doctora Begoña, estamos sin audio.
Dr. Begoña, you are muted. Okay, so I'm going to give the floor to Dr. Carolina. I'm sorry, before closing, there is a question that says, what are the main challenges to reach these pharmaceutical sovereignty in our region? These are very complicated questions. Thank you very much. We have worked permanently with academia. Academia has been involved in all discussions, decisions, and the process to reform the health system in Colombia. But besides the academia and civil society and social movements, they have been a spearhead in Colombia that I think not only in Colombia, but also in the world, the public policies transformation agendas have not been chosen by parties, by political parties or by the academia, but by social movements. We can see this, for example, in all that has to do with the environment, with feminism, etc. Like in the Colombian case, the health reform has also been led by a social organization, social movements, and not mainly political parties or the academia. And regarding pharmaceutical sovereignty, I think that this is a challenge for all systems in the world because technology, actually the challenge that we have, and I think that we share that with other countries, is to generate evaluations to enter technology and medicine to the country with public funding, something that's not financed by pharmaceutical companies like it's in the case in Colombia. We also have to create awareness. I have met medical associations, medical faculties, and we need to have awareness. Um, we need to have medical autonomy and autoregulation, and they need to know how important it is to not deals with pharmaceutical companies because this impacts public spending. So we have to do work with medical bodies so that they are aware of health justice. Okay, now I'm going to go to Brazil, please. What about human resources? Can you please talk about human resources as well? Please go ahead, Dr. Marco Vinícius.
Well, since I said in the beginning, I come from the single healthcare system and I am a doctor. I underwent my
Graduated
studies in a public school. I am
from
an
medical career
orthopedist
in a
and I
public
trained.
university.
I had my
I am a
internship in a public
traumatologist,
hospital, and in Brazil, we are always in touch and always
and we are
exchanging
in
experiences
constant
with
contact with
universities, especially
universities
the
to
public
exchange
universities. In
experiences,
fact,
especially with public
human talent
universities.
is our greatest good,
Human
and
talent
the
is a
single
great
healthcare system's
asset.
greatest asset. And in our over
Is a great
5,000
asset
cities,
at
there is
SUS.
always
In our big
someone
cities,
who
we have
belongs to the SUS
public servers
serving the
from
population and
SUS,
motivating this person,
and
protecting
we
them, and
motivated,
investing
we
him,
protected, and we
investing in
invest in
their
it so that this
involvement
can
as
be
a professional,
perfected.
if you
And this
can,
is
is
one
one
of
of
the
the most
most important
important
strategies in the
strategies
Ministry of
that the
Health.
health the health ministry tries to implement
And
with
with digital
digital communications,
communication,
in which
this
we can
we
speak
can
as if
still
we were
have
together
conversations
in
as
one
if we were
room,
in the
even though
same
we are
room.
far apart, has
And this
helped
is
us
also a
to
tool that helps us
disseminate knowledge. It is in our view, an important strategy, and the
spread information
pandemic has really
education.
strengthened the
And the
digital
pandemic also
aspect
made
of
this
healthcare. And
digital
nowadays we have
health
passed a
world
law that regulates
bigger and faster. And now we
telehealthcare, that
have
is distance
telehealth
healthcare,
with a
uh,
diverse
within
specialties
public and within private
in public
healthcare
and in private health. We also
systems. And we
have
also
a
have a
virtual
virtual
university that
university that helps
allows
workers
for
from
workers
Brazil
in all the
to
country to be
undertake
trained
their studies in a permanent training
and
systems.
permanently
Really
educated
cannot
in the
help.
health
And
area.
just to wrap, I would like
And
once again to thank you for
to
your invitation,
finish, I
and
would
I would
like
like to
to thank you
underscore
again
that
for this
the
invitation.
single healthcare
And I would
system in
like to
Brazil,
tell you that
SUS, is a
SUS or SUS in
social
Brazil is a social
social
conquest.
construct. We
Here we
had
have a
a vibrant
vibrant
democracy.
democracy.
Now
We are going
we
to have
are
our
facing
elections soon.
elections, and none of the
And
ideological
the
standpoints,
different
socialists,
ideological parties,
market liberals such as
socialist
the
or
government
Bolsonaro
of
party,
Bolsonaro and
don't
others,
see
try to
going back as
underscore
a
the
possibility.
universality
We
of
cannot go back
uh,
regarding
healthcare
health
services.
universality.
We want to make sure that
So
SUS
SUS
keeps on,
is
no
something
matter
that we
what
have
the
achieved
ideological
independently
standpoint,
from a political ideology.
from now on.
And
And
we
the
have
Brazilian
to
government is a
work all
partner of
together to
OPAs and
exchange
several
experiences.
projects in Brazil and outside
Ministry of
Brazil. And
Health
once
in
again, I would
Brazil
like to thank
is a partner
the
of
opportunity
PAHO.
of being here with you.
Thank you very
in
much
this
for
very
the
August
opportunity to
discussion.
participate in this discussion. Right. Thank you very much for your closing remark. We wanted to ask Dr. Begoña and Dr. Carolina to give their final messages. We still have many questions. We still have many topics. And one of the main topics is how our countries can guarantee capacity of answers in different territories in a decentralized manner. There are many, many, many questions. We will not be able to ask every one of them. And for Dr. Begoña, could you please talk about human resources and pharmaceutical sovereignty? So now I'm going to give the floor to our two ministers to close for their closing remarks. And then we will have a summary of everything. So please, Dr. Begoña, go ahead. I would like to tell you that I have been reading all questions in the chat box. I think that this creates a space for conversation that's incredibly rich. I think it's very important to look at our territory. Chile is a country that has a very big geographical diversity. And we have a lot of social and historic interactions. And the sanitary system has to be aware of this, because if not, the results will not be appropriate. And in this government, we are developing a rural health program for indigenous peoples. Because when public policies are centralist and they don't have territory pertinence, there's a lack of access, there's a lack of adhesion, and not including indigenous people generates a lack of confidence in the health system. And so a very important part of our system is to make policies more territorial and be pertinent in that sense. And this is a feminist government as well. And these two elements are present in all public policies. In terms of financing, we think that all contributions have to be put together, made collective, and we have gone from 4.8 to 5.8 or 6% of GDP. And with that, we have reached a funding level that is close to recommendations from international organizations. And here we also have the state contributions to the national health system. And finally, regarding sovereignty, we believe that Latin America has learned through the pandemic and through other challenges, like, for example, the monkeypox. We have become aware that we need to have sanitary sovereignty. We need to be able to produce vaccines and biological medicines, but we also have to coordinate our regulating bodies, have a continental spirit regarding our regulating agencies. We also have to do purchases together. We need to develop a capacity as a continent to have timely answers to other challenges, to other global challenges. And we also need to improve our quality response. So we want to work together with the other Latin American countries, not only in the health reform, which is huge, We also want to change the sanitary system so that they are more just and more equal. But we also want to join the conversation on a sovereignty that needs to be continental and not only national. Thank you very much, Dr. Begoña. I'm going to give the floor to Dr. Carolina. Thank you very much. I'm going to answer some questions. It was established that EPSs were private insurances. Yes, that was the aspiration at the beginning. Private insurance in health has two features, managing financial risk and financing health risk. The financial part has to do with liquidation. There has to be a mechanism that covers the debts with hospitals. That did not happen. We have 150 liquidated companies, and they do not comply with that sense. There was no capitalization either. Uh, Most of funding resources came from the state with the prosecutor's office and the para prosecutor's office. And regarding national expenses, um, it was 3.5% of GDP, and now it's 7%. They are not comparable systems because if you have such a low public expense, you cannot compare the health system, the public health system, and the private health system, because there was a fragmentation between social insurance, charity hospitals, and private access. It is not comparable. And the reform has nothing to do with this. The other thing is about oligopolies. This was mainly about transnational pharmaceutical companies. When you have power with the Congress was destituted because the FAS pay them so that they would vote public policies. So oligopolies are not good, especially to guarantee fundamental rights with public resources. Another question regarding private clinics. 80% of services are private clinics and 900 public hospitals and 15,000 private suppliers. Of course, they have to continue to work, and the state has to reinforce hospitals, but this has to be integrated. Both sides have to be integrated so as to give good services. Uh, and in the reform, will we give resources to territorial entities? No. That's part of the propaganda in Colombia. Here, the resources will not be given to the health secretaries, only the resources that have to do with them and that have to do with prevention and promotion. And there is a public fund that manages the resources, and the idea is to have a change here through an audit. And the reform is not statizing. There is a strong component from the private sector. We're not going to statize anything because they already belong to the state. We're going to do an equal distribution. So the state has to do a compensation so that there's an open hospital 24 hours a day. So that it is open in the areas where there are poor people. Okay, so that is a summary of our reform. Okay, so on Wednesday, September 7th, we will have our second component, and everyone that was registered in this call will receive the next invitation. And now I would like to go to Ernesto Mascro, and he is our advisor in policies and planning. And so he is going to do a summary of everything that we have talked about. Please go ahead, Ernesto. Thank you very much, Mónica. It has been a pleasure to witness not only the presentations, but also the very rich exchange of topics. We have seen a clear picture of the health systems in the countries, but also in the region. And there has also been very interesting to understand the processes, historic processes, historic transformation processes for these countries and the region. This is the first thing that I would like to underline or to highlight. It was very interesting to hear about the context in the three cases. Very often we say that we shouldn't sell recipes from one country to another country. And so I think that the explanation of the three cases were very relevant to explain the current challenges in the countries. But at the same time, in the three countries, in Chile, in Colombia, and in Brazil, we analyzed the transformation processes in the last 2 or 3 decades. We saw the progresses, the strengths, but also the weaknesses and the fights to guarantee universal health coverage in the three cases. The second thing that I would like to talk about is the fundamental weight of health as a structuring goal of transformation processes. Okay, to analyze how to intervene in problems, I think that there was an essential topic. Not only to reach efficiency, but also to have equity. It has been a central element to explain rationality in terms of interventions and the logic behind transformation processes. But the same process that has had a lot of weight when we talk about health is interpreting health as a right, as a fundamental human right. And this has to do with central values that are included in the national health strategies that the PAHO member states have incorporated in a very clear manner in this 2014 strategy. The third thing that I would like to mention is a description we have to analyze in an integrated manner the governance and the funding and provision of resources. And we have to have a distinction between rectorship and the capacity to lead from health authorities to transform governance mechanisms into to guarantee the fundamental right to health. And the third element was very present, especially in Colombia and Chile, was the relationship between governance and funding. In the case of funding, I would like to highlight three elements that are very related. First of all, the need to increase public funding. And in many cases, it has to do not only with prioritizing public funding, as part of contributive capacity of the states, but also to increase public funding through different sources. And I think that this has been expressed in the case of Chile and the case of Colombia, and it has to do with tax reforms that are behind and that support these processes, these transformation processes, and that make sustainability possible, not only for a measure, but also for transformation processes. The second financing element had to do with solidarity and guaranteeing pool of resources. And there is also participation of private actors to manage public resources. That is something that PAHO has systematized. These are experiences that have been systematized, and I think that this can be incorporated in the reform agenda. And it has to do with one of the central points, the relationship between the private and the public. And in the three cases, we mentioned the necessary participation of the private sector to be a part of the health network. And I think that it has been clear that in the three cases, it has to do with necessary strengthening of the state's regulatory capacity regarding the participation of the private sector to guarantee that this participation is aligned with public policies to ensure public health.
The next point that was also present in all three presentations has to do with governability and service provision in all these processes. I believe that there is a trilogy that was underlying all these presentations and the debate, that is the inequality of access, because we need a justice, fair access to health services. And this is a central element that is having an impact on the health situation of the country. And when we talk about inequality of access, there has been a very clear presentation about the different barriers of access is explained in the different contexts, not only national but also subnational, understanding the challenges in terms of different social groups and rural populations, etc. And this inequality in access is at the heart of all three presentations, and it has to do with reinforcing the primary health care as a way of transforming service provision. And the last point is about the relationship between governance and resources. And I believe that this issue of generating resources is also divided into two. One is about technology, medication, vaccines, infrastructure, and this is one of the issues that was explained very clearly as a challenge ahead in these reforms, and even in terms of sanitation, in sanitary sovereignty, of health sovereignty, and of going beyond the national level by building a regional agenda. And I need to mention that the member states of PAHO decided to increase the productive capacities of the region for drugs and infrastructure. And so a regional platform was developed with big projects and financing, and through this platform, we will try to increase the production capacity in terms of vaccines, but also other technologies. And this platform is a facilitator, an articulator of a cooperation uh, uh, initiative in which many countries are participating, such as Mexico, Brazil, Cuba, Colombia, among others. And so we could incorporate this model as part of global health and as a main condition, not only for the conditions of health of the population, but also to think about this as a collective action that requires the cooperation of the different member states. And another one of the elements that was discussed, and here I end my presentation, has to do with the indispensable role of academic institutions together with social movements, and not only as actors, as Dr. Carolina was saying, not only to guarantee responsibility in the role, for example, for prescription drugs, in order to guarantee equality of access, but also the need to incorporate these actors as allies, as a part of collective action together with the government, and in order to build legitimacy and guarantee this legitimacy in terms of policies, in order to, well, establish all this kind of principles. I try to summarize all the debate and the statement, and I believe that this should be the first of a seminar of a series of seminars about articulating healthcare services. Well, thank you very much, dear colleagues, for this marvelous meeting. And we would like to ask the colleagues to open their cameras to take a picture, because it's such a nice thing to be able to see each other. And well, colleagues have asked us in the chat if they need to subscribe to something, but we will send you the invitations for the next meetings. Thank you very much, and to all the Washington team. And well, I was supposed only to close, but I would like to pass over the mic to James. Well, thank you, Mónica. No, I won't say much more. The richness of this analysis, the depth of it is very clear. We really congratulate Chile, Colombia, Brazil for explaining the complexity of these processes. And so we will continue from here with all countries of the region to advance in this. And because all the countries, families, etc., are involved in this. So thank you very much. And we will close here. Thank you to all of you. This is, I like the word continental spirit. So thank you very much. And we'll see you later, another day. Thank you, everybody. Up to next time. Okay, bye. Thank you. We had 150 participants, and that's a lot. We're very happy. So I close here. Thank you.